hopefully this patient would be on the Keynote 189 regimen for a very long time, but we don't think that the regimen cures patients of their stage 4 cancer. That may happen in a small number of patients, but for the most part, we would anticipate that our patient for discussion today at some point would exhibit disease progression. Presumably, if he was on pembrolizumab for a long period of time, I would think about, depending upon how long he was, I think the options would be categorized as follows. The standard option, kind of the textbook option, would be to go to what I would call the standard second-line treatment, which would be docetaxel with or without ramucirumab. Typically, I do use ramucirumab. We have phase 3 data from the REVEL trial that shows that the combination is better than docetaxel alone. That's probably the most common thing I do. Now, some thinking out of the box options would be, maybe would you add chemotherapy back on into the mix with pembro for 2 to 3 cycles to see if you could reinduce a response. We don't have any rationale for that at this point. If you have gone for, say, more than a year before you've had chemotherapy, there is precedent that many tumors, you can see repeat sensitivity to that. So that would be an option, although I must say we don't have any clinical data to date. We also know that there's a little bit of a fuzzy area in terms of continuing immunotherapy past progression. And that has a lot of nuance to it. There are some people that I would try to hang on immunotherapy for a while. There are others that I clearly would switch to, say, docetaxel, ramucirumab. It would have to do with the bulk of their disease, how quickly were they progressing, how symptomatic were they, and these sorts of things. If they were progressing rapidly, they had bulky disease, they were very symptomatic, I think you have to abandon the approach of immunotherapy and go back to chemotherapy. And typically I would use docetaxel, ramucirumab. Again, I would think about going back to, say, carboplatin, pemetrexed, if it had been more than a year, although I have to admit it's a relatively data-penic zone, if you will. There's not a lot of data in that setting to give us really good guidelines. Between AACR and ASCO this year, we had a titanic shift in the standard of care. Trials like Keynote 189, Empower 150, Keynote 407, and Empower 131 in squamous really changed the standard of care. Essentially what we've done is to take the chemotherapy that we used to do first line and immunotherapy, which was the standard second line approach, and we've combined them. And by combining them, we have improved outcomes both in non-squamous as well as squamous. So I think this is wonderful news for patients, and we've done that without substantially putting patients at risk of significant toxicities. We have to be aware of the side effects, but these regimens, combining them, have very nice tolerability profiles, and the toxicity is certainly not prohibitive. So it's a new dawn about using immunotherapy, sometimes alone, sometimes with chemotherapy, that really improves outcomes for patients with advanced non-small cell lung cancer.